can vary tremendously from child to child or adult to adult. So I think of it as a rule of threes. You can have stool output that is as infrequent as every 3 days or as frequent as 3 times a day. And everything in between that is classified as normal. Sorry, I just had a pop up. Okay. The other big question that I see or that I get from parents a lot of times is it abnormal if the child, their newborn or young infant, is straining so much? So I get a lot of parents who come into the clinic and say, my child is constipated. This baby, this infant, 1 month old, 2 month old, 3 month old, is constipated. And they use this term. And when I ask them to describe, what does that mean? Describe what's happening. What do you see going on? And they'll say, well, they are crying and get really fussy and they scream and they turn really red in the face and like they're bearing down trying to poop. And then all the poop comes out really soft or loose even, but it looks like it hurts them to poop. And so they're thinking of this as a definition of constipation, when in fact it is actually a normal process that we call infant dyschezia, which is really the child trying to figure out how to actually relax the external anal sphincter and get the stool to pass. You have to bear down and contract your muscles in your stomach at the same time as relaxing the anal sphincter to allow passage of the stool out. That's a very difficult process for a baby to understand. So, as you might imagine, they have different mechanisms of trying to make that happen. And one of those, they increase their abdominal pressure by bearing down or screaming or crying. And so that is a very normal process. And once they figure out how best to get the poop out and coordinate all of those muscles and that nerve response, then they'll stop doing that. So it's just as easy as that. Similarly, the form or the consistency of stool can vary greatly. So I have it generally in my clinic, I have a Bristol stool chart pulled up on the wall, and it's and I have the parents or the child point to like, what is the consistency of the stool that you see on a regular basis. Some of these are very bright and colorful and very fun, and they liken the stool to different foods or different animal type poops and everything, so that it makes it fun for kids. But normal soft formed stool would be somewhere between a Bristol 3 and Bristol 4. If a child is having very hard, painful stool that is causing them discomfort with passing the poop, then that is abnormal, just as the opposite end of that spectrum, which we'll get to later, which is having a very watery or loose stool that is profuse. Okay. Let's see. And just to clarify on the infant dyschezia, this is a behavior and not a disease. It is not a response to a painful stimulus at all. Okay. So how does digestion occur? So this is really just a diagram for some of the parents that may be watching and trying to figure out like what's going on inside of the gut. What are we talking about? So as we eat and consume food, it sits in our stomach for a number of hours, anywhere between 1 and 4 hours, at which point it is slowly trickled into the small intestine. Your small intestine is where digestion begins. that is the site and the location where every single nutrient that your body needs is picked up and absorbed. You have these finger-like projections that are called villi, and all the way along each of those finger-like projections, we get absorption of nutrients. Once the food, so that passage through the small intestine is a very slow process. It can last many hours. And once the food and the nutrition has made its way all the way through the small intestine, what is left is the waste. So it's whatever was not absorbed within your intestine. And that slowly then trickles into the colon. Your colon begins here on the right lower quadrant of your abdomen. So this is you looking at a patient, or you looking at your child. So this is actually the right side of the person, and this is the left side. So stool enters here on the right side of the abdomen in the cecum, and then as it moves along the colon and makes its way out of the colon, there's a process of dehydration of the stool. So everything that enters the colon in the cecum here is liquid. Every single bit is liquid. It does not begin to form until it begins the transit through the colon, okay? And this is where we start to see constipation or diarrhea really begin, okay? So your colon primarily has three functions. The two that I'm most interested in right now and talking about is really the storage of feces and water reabsorption within your bloodstream. So this is that exit from the small intestine and entrance of the stool, or the liquid stool, into the colon. And as it moves along, we get water reabsorption back into the bloodstream, okay? So let's define chronic constipation. Let's talk about some of the causes for chronic constipation, and then how do we manage that? How do we treat it? So constipation is actually defined as delayed or infrequent passage of hard stools. As we talked about before, if you have more than 3 days without passing a stool, then you technically have constipation. It can be acute onset constipation, which all of us experience at one time or another. Could be associated with an illness or infection, could be associated with your decreased oral intake. Lots of things can cause that acute onset constipation or that intermittent constipation. What we're also going to really dive into is more of the chronic constipation. So it's a pattern that is repeated and going on consistently for months at a time. All right. Constipation can also be defined as painful passage of hard stools. And again, each of us has experienced constipation at some point in life. If you haven't, keep living, as my grandparents would say. All right, so there are definite diagnostic criteria for functional constipation, which is what we call chronic constipation in children. Functional constipation is defined into categories based on how old the patient is. So in infants and toddlers, okay, sorry, I keep getting messages on the screen. In infants and toddlers up to 4 years of age, constipation, for constipation to be diagnosed, you would need to have two of the following symptoms. So 2 or fewer defecations per week, a history of excessive stool retention, a history of painful or hard bowel movements, large diameter stools, or presence of a large fecal mass in the rectum. If the child is toilet trained, then you can use the additional criteria here, which would be incontinence or leakage of stool. And that is something that we'll discuss in just a moment. That is when a child is not aware that they are passing a stool, okay? For kids who are older than 4, they're much the same. You get a little bit of difference here with the verbiage for diagnosis, and you can read here for those diagnostic criteria. Okay. Now, the times when I see constipation happen, I really see them at 3 sort of milestone parts of childhood. Really, in infants, I get a lot of patients come in with constipation symptoms once they start to eat solid foods. So as they're transitioning or as they're drinking formula or breast milk, and then parents begin to introduce solid foods to that child, then they start to have more formed stools. If they are young enough and they still are having trouble trying to figure out how to, bear down and pass those stools easily, then that more solid consistency of poop is more difficult for them to pass. And so we'll start to see a lot of grunting and painful passage of hard stools. Once they start consuming formed like solid food, then you get more waste that is not absorbed within your small intestine, and so you have more form to your poop. It's just a natural thing. So depending on what they eat, they may have harder stools as well. The second time when I start to see kids develop constipation or have a bout of constipation is around the time of toilet training. This can be associated with fear of the toilet. It can be associated with, I've had some patients who have, to talk about fear of the toilet, who have done well at home, and then they go out and there may be a public restroom with an automatically flushing toilet, and the children are terrified of that, or they're terrified of falling into the toilet. There's a number of reasons, and so they'll start to hold their poop and not go on the toilet anymore. The last time or the next time that I see constipation begin is really when kids begin to go out into school and they don't want to poop at school. So they start to hold the stool during the whole school day, and then when they get home, they'll pass a hard poop or something like that, or they won't go for a couple of days, and then the stool becomes very hard. They finally poop, and then it becomes a vicious cycle of painful passage of stool. So if a child has a hard stool that they're passing, that is traumatic. I call it post-traumatic pooping disorder. So kids, and really no one likes to do anything that is painful. So we avoid it at all costs. And pooping is no different. If you are having to poop very hard, large poops, then you will do everything in your power to suppress the urge to go poop. And that's what children do. That's how it begins. It becomes a vicious cycle. If you remember a couple of slides ago, I told you that your main function of your colon is to reabsorb water. Well, as it happens, when the poop is transiting through the colon, it gets drier and drier and drier. If you're not emptying the colon consistently, then the stool will continually get drained of fluid, and it becomes harder and harder and harder. So really, the vicious cycle is they're trying to avoid a painful, hard stool by holding the stool in, when in fact, that's what's causing the painful, hard stool. So the treatment would be to get them to change that behavior, okay? If patients have slow transit through their gut, so their intestines are not moving at a normal pace, then you can have longer contact with the stool in that colon, so it gets drier and harder, even if the kid is not trying to hold their stool. You see that a lot of times. I linked with the one here at the bottom, low muscle tone. So in my patients who have like cerebral palsy, who are or those who have whatever illness that causes them to not be ambulatory. That lower muscle tone, primarily in the abdomen, can prevent the normal contractions of the colon itself. And then you have stool that's sort of not moving appropriately. Again, we talked about toilet training refusal and the fear of toilets. Stress in general can cause this as well. You have a presentation of irritable bowel that is primarily constipation predominant. And so that also can contribute. And then, as we discussed before, poor appetite if you're not consuming food. Holding behaviors, also called posturing, are sometimes difficult for parents to grasp what that means. You'll see the child standing stiff, as you see here in this photo, or they may be crouched down in the corner up against the wall. Typically kids will go and hide, or they'll try to sort of hold their stool in, cross their legs really, really tight. Some of them may even sit on the toilet and just plank completely, like straighten their body and try to get as tight as possible. Parents think that this is the child actually straining, trying to poop, when in fact it's the opposite. They are definitely trying to suppress the urge to poop and to keep the poop in at all costs, okay? There also are multiple medications that could be contributing to constipation. This is something that you need to be aware of and be thinking about. And that can, worsen a situation. Obviously, children need medication sometimes, and so it can be a situation where we cannot avoid it. So if they are on anticonvulsants because they have a seizure disorder, I'm not going to stop their anticonvulsant just because it causes horrible constipation. Instead, we will treat the constipation to the other particular medications that I see frequently are ADHD medications and bedwetting medications. Those are commonly used for our patient populations. And a lot of children who have chronic constipation will also have urinary or recurrent urinary infections as well. So less common causes would be spinal cord disorders, so spina bifida, which we can see. It's not excessively common, but you definitely have neurologic findings that are consistent with that and would point you towards that being the cause of constipation. Certainly not the average child that is that comes into the office. There's also disease processes like Hirschsprung's that is caused by a lack of migration of nerve cells to the end of the colon, can stop anywhere along that transit, and it causes the colon to not relax appropriately. This is something that we typically find in infants. It is not a disorder that is generally diagnosed older in life. And so I try to help parents understand that is 99% of the time not going to be your child's problem. Celiac disease is another potential cause of constipation. It's not very common for it to cause constipation. Classic celiac disease causes diarrhea, and we'll discuss that in a little bit, but it can cause constipation. And then low thyroid function, which the majority of the time in pediatrics, we are checking thyroid function as in infants. So that's not something that we will typically see. All right, so chronic constipation can definitely cause abdominal pain and fullness, decreased appetite, bloating and distension. You can see small amounts of blood on the stool, as pictured there. It is not going to be a diaper full of blood with no stool, but you can see tears on the bottom from passage of hard stools that has torn the anal tissue. You can also have smears or leakage of stool in the underpants, which is called encopresis, and then repeated urinary infections. It does not, however, cause headaches, halitosis, learning problems. It does not cause a backup of toxins in the bloodstream. It does not cause your colon to become ruptured, and it does not cause colon cancer. These are all things that I've heard over my 10 years of practice in pediatric GI that parents come in very stressed about these issues happening with their children or potentially happening. We have, everything in our body is run by nerve interactions. So you have a brain-gut axis, and whenever you eat, you have a gastrocolic reflex. So whenever you consume food, your stomach stretches and causes contraction throughout the intestine. And then that contraction moves things closer to the end of your colon or your rectum. And when stool enters the rectum, you get another stretch response that sends nerve impulses to your brain that tell you it's time to go poop. When you chronically ignore those sensations, that's when you get desensitized to that nerve input. And that's when you can have the backup of stool in the rectum, or what's called an impaction, fecal impaction. When you have an impaction, that sets you up for leakage of stool around that impaction, which is called encopresis. So this is basically just a picture of how that happens. Your colon is very capable of compensating and allowing for space to hold the stool. Remember its function. It is it's there to store the stool. So it accommodates large masses of stool, and we get this backup and sort of bogginess to the colon itself. If you remember at the very beginning, I told you that everything that enters the colon is liquid. Eventually, as things transit over, that more liquid stool will seep around this massive impaction and then begin to leak out of the anus. This is not something that the child is aware of. And more often than not, I get angry, frustrated parents coming in talking about the child is pooping on themselves and is having issues, or they're getting in trouble at school because of having a dirty, having to go to the nurse and clean up all the time, or not smelling good, or, whatever, getting bullied at school because they stink, etc. And truthfully, it's not the child's fault. They cannot feel this. There is no stretch response like in the normal brain or normal situation here. So the treatment of this is really to do a bowel clean out to get this fecal mass out, and then continue with medications to keep the stool soft and promote regular, consistent defecation. All right, so how can you help your child? Primarily the initial treatment is a bowel clean out. So using the osmotic laxative like Miralax to help liquefy the stool, clean out any impaction of stool or mass of stool that's there. And then you go into these other things. The biggest change, or the biggest, most important part of this, important piece to this puzzle would be behavioral modification, if I had to choose any of them. Without creating a new behavior, the child will revert back into constipation every single time. It will never get better. So even with infants, when you start seeing these holding behaviors, the stiffening of the legs, that refusal to poop, trying to bicycle their legs and get that stool to go ahead and come out, sort of breaks that cycle of holding. And so we get past it in that manner. And you may even in an infant have to use something to soften the stools. We use medication like lactulose, or even we'll utilize Miralax. Some infants are very sensitive to juices, so the non-absorbable sugars in juices that can act as laxatives. For toddlers, just encouraging that toilet time, having stools that are appropriately sized, so that they are in a good position to poop, or putting a stool underneath their feet. Those are also very helpful. Disimpaction is generally not required. Using the right medications is the other piece of this puzzle. So softening the stool is important. Remember, kids don't want to do things that are painful. So if they're still having hard poops, they're not going to abide by the behavioral modifications. And then occasionally we have to use medicines that force them to poop. These are stimulant laxatives like Senna and Dulcolax. So, all right. So, and then the other thing that I love to tell parents is keep calm, like not fighting with the child about their soiling accidents if that's what's happening, okay? But giving their medicines at the correct dosage, the correct frequency, and timing of that. All right, there's a video on YouTube if you ever want to watch this, if you're just like bored and you have nothing else to do. Hey, it's called The Poo and You. Colorado Children's put it together. It's a wonderful example of what goes on to cause constipation and how we manage it. It basically is a recap of everything that I just said. Okay, so chronic diarrhea, just going through a few things from that aspect. Diarrhea is broken into two different categories, acute and chronic. Acute being the abrupt onset of having 3 or more loose stools per day, and it does not last more than 2 weeks. If you have if you have 3 or more loose poops a day that's lasting more than 14 days, then you technically have chronic or persistent diarrhea. So today we're not going to deal with the causes of acute diarrhea. Instead, we will deal primarily with chronic diarrhea. There are a few things: toddlers' diarrhea, lactose intolerance, infections. These are just a few. Malabsorption, which can be caused by some disease processes. It also can be caused by a number of other disease processes that we won't go into today. And then some intestinal surgeries that can use chronic diarrhea. So toddlers' diarrhea is non-specific diarrhea of childhood is the other name of it. It generally affects kids from 6 months to 5 years of age. They can have anywhere from 3 to 10 loose stools per day. Their stools usually happen while they're awake, so they're not having to wake up and go poop. And it can be immediately after they eat. So they'll sometimes be starting to eat and then have to run to the bathroom. Okay. Generally, the poop is watery and loose. You can also see some undigested particles in their food, like you will say, you ate carrots or you had some blueberries or whatever. You can see it in their stool, but it should not contain blood. The stool consistency also can vary from day to day. So one day they can have really loose stool and another day they can have more formed stool, okay? You also have no red flags. So again, no blood in the stool. They're growing and gaining weight appropriately, assuming that they're consuming enough calories each day. They have a normal activity level. Their appetite is normal. They're not complaining of severe abdominal pain. They're not doubled over in pain, etc. So those are If they had any of those symptoms, they would technically have red flag symptoms that would take them out of this diagnosis. Toddler's diarrhea is probably the most common thing that I see in children. It is completely benign and goes away on its own without any intervention. We don't know why it happens. Sometimes you can have a little bit of faster transit of the food or the waste through the colon. So we have decreased contact with the colon. And if you remember, your colon reabsorbs water back into the bloodstream. So if things aren't staying in the colon for long enough, then you don't have enough time to reabsorb enough water or fluid, at which point it all just comes out. So that leads to those loose stools. Again, consuming things that have a lot of sugar in them. So juices, fruits, eating lots of fruits, eating candies or sugary foods, drinking sports drinks that have loads of sugar in them. And even especially foods or beverages that have sweeteners in them. So high fructose corn syrup is a big one, sorbitol, xylitol, mannitol, isomalt. Those are non-absorbable sugars. They promote or draw water into the intestine and cause you to poop more fluid, okay? So you have to really be careful about how much these children are consuming of those things. Lactose intolerance is the second thing I wanted to go over. So lactose with an O is the milk sugar. It's found in all types of milk products, and you see the list there. Lactase with an A is the enzyme. So it's the protein that is an enzyme that digests or breaks down the milk sugar lactose, okay? So having a lactose or milk sugar intolerance means that you develop symptoms of maybe abdominal bloating, flatulence, abdominal cramping, et cetera, associated with consuming milk products that contain that sugar, okay? And the reason for that is your enzyme level, your lactase enzyme level is not high enough, okay? So if I only have this amount of enzyme in my body and I'm consuming this amount of sugar, then I can't break down enough of the sugar and I have excessive amount of sugar that's going to promote diarrhea, symptoms of bloating, distension, pain, flatulence. So it's very common, especially in African-American individuals. More than 80% of us develop lactose intolerance over time, okay? Typically starts in school-age kids. It can be as late as teenage years, but really can occur anytime. I personally did not develop lactose intolerance until I was in my 30s. So, really have to watch for it and think about it and use it or put it in your differential as to what could be causing symptoms. We are all born with lactase enzyme. It's a requirement because lactose is the primary sugar in breast milk. We are mammals. We have to have milk in order to survive. But we were not made to consume milk as our sole source of nutrition for our entire lives. So as we get older, that enzyme level in all of us reduces to some degree. In some of us, it completely disappears. Good job, us. So acquired lactose intolerance can develop after an infection. So young kids who have a gut bug or an infection of some sort can, for a short period of time, have lactose intolerance. Sometimes when I have a baby who has recently been sick and is just having loads of diarrhea and they should be over that sickness, I may switch them to a different type of formula that does not contain lactose to see if that will resolve their diarrhea. And we may continue on that for the next month or so until they're all better, at which point we can switch back to their previous formula. So that is generally acquired and is a temporary shortage that will resolve, okay? But around 3 to 6 years of age, we naturally start making less of that enzyme than we did in our first 2 years of life. So we treat this by either taking medicine over the counter, which is a lot. It's easier just to avoid. Just avoid all dairy. If kids are like, I cannot survive without ice cream, then it's fine. They can take the chewable pills or the drops or so before they consume dairy products. If that works, great. If not, I'm sorry, you're going to have to avoid and have a strict lactose-free diet. It's important to remember that we have to have vitamin supplementation if we're not consuming the dairy products, because dairy does provide us a good source of calcium and vitamin D and the riboflavin, which is one of the B vitamins that we require in our diet. So taking a good multivitamin on a regular basis is critical. All right, so as far as the infectious diarrhea, most infectious diarrhea is self-limited. C. diff, Giardia, and Cryptosporidium can all cause a prolonged or protracted course of diarrhea, landing them into the chronic diarrhea categories. Giardia and Cryptosporidium are parasitic infections. They typically infect immunosuppressed patients. So the times when I've seen these infections, they've been in my transplant patients, those who are chronically taking medications to suppress their immune response. And in those individuals, these can be very, very severe, very serious infections that are difficult to treat and manage. C. difficile is a little bit less common, I would say, in my kiddos. I think it's something that we kind of overcheck for. But again, it typically will affect immunocompromised patients who are on long-standing acid suppression, so your Nexium and Protonix and omeprazole and those types of drugs put you at higher risk of these gut infections. And then patients who've been on recent antibiotics. So let's talk about C. diff for a second, or Clostridioides difficile. So C. diff is a bacteria. It's normally in our gut. We usually have it in very small numbers. I like to tell people we keep it in check in our gut, okay? There's a very healthy balance of bacteria and all of these necessary things in your gut. When that balance is thrown off for whatever reason, infection, medication, if you take antibiotics, etc., that balance is shifted so that the C. diff bacteria have a chance to overgrow. When they overgrow, they start taking charge, and they are classic for producing toxin that will then cause damage to the intestine. When we're born, we have C. diff in our gut, and usually you don't get it to like low numbers until you're over a year of age. So it is standard for us not to test infants for C. diff infection. So when we have a C. diff infection, that toxin has sort of overwhelmed our colon. We can, your colon then becomes inflamed. An inflamed colon doesn't do its jobs. And one of those jobs would be to reabsorb fluid. So it's unable to do that job, and you get, as a result, profuse watery diarrhea, okay? You can also see blood in the stool with the C. diff infection because of inflammation and sloughing of the tissue. When you have very severe disease, we'll talk about that here, So in severe infections with C. diff, you can get fever, low blood protein or albumin levels. You get elevated white blood cell count, which are your infection fighting cells, and then even pseudomembranes, which can form within the colon. They look like, when you look at them directly with a scope, they look like yellow patches. They're sort of yellowish, whitish patches that are scattered throughout the entire colon. And it's really just damaged tissue and sites of like deep infection. All right, so how do we treat it? If you only have mild symptoms, then and you are on antibiotics, then we can stop those antibiotics. I always encourage parents to give probiotics while they have a child that's taking antibiotics. That is the one area that we know probiotics can be helpful. That's in preventing antibiotic-associated diarrhea, which would be this, okay? So give the probiotics to prevent infectious diarrhea, okay? You have to monitor these patients closely for weight loss, for dehydration, as I just described, profuse watery diarrhea, okay? The colon's not doing anything it's supposed to reabsorb water. So you have to give that back to the patient. Hand washing is optimal. Like, you have to be on top of good hand washing practices so that you do not spread this infection. It is highly contagious. C. diff lives in spores, and you can actually reinfect yourself very easily. So in severe infections, we have to use antibiotics. We usually reach for either metronidazole, which is a flagell, or vancomycin to treat severe infections. And again, so if we are reinfected, it's not because it was incorrect treatment or poor treatment in any way. It is primarily because you reinfected yourself. These spores can live or remain in the body even after that initial infection is managed. All right, so we'll move on to celiac disease. Celiac, briefly, is an autoimmune disease, which means that it is your body's immune system fighting your own body, okay? The site of attack is always the small intestine for celiac disease, okay? So your immune system starts fighting your small intestine, and it only starts to fight your small intestine after it has become sensitized to gluten. Gluten is the primary protein in wheat, barley, and rye. And individuals who have celiac disease, when they consume gluten or products containing gluten, it causes their immune system to ramp up and create antibodies, which I think of as like little soldiers that are fighting everything. And so these antibodies find their way specifically to those villi, those finger-like projections we talked about in the small intestine, that are responsible for picking up all of your nutrients in your small intestine. And these antibodies come and directly attack your villi, okay? It causes them to be stunted and causes them to be lined with inflamatory cells. And so as a result, you do not absorb the nutrients that you normally would out of your diet, okay? So when you're not absorbing your nutrients, you have more waste made available. Your transit time's probably going to be increased. So you can get profuse diarrhea as a result of that. But also you get failure to thrive. You don't grow well because you're not getting your nutrients, okay? So this is also called celiac sprue. It's also called gluten-sensitive enteropathy. So it has a couple of different names. It's all the same thing, all the same process, and all the same treatment. So Some patients are completely asymptomatic. They have not one symptom at all. It's a silent disease in these individuals. And that to me is a little bit scary because you don't know that you need to be treating. But most classically, patients will develop chronic diarrhea, bloating, gas, failure to thrive, and then have this growth or pubertal delay, iron deficiency anemia because of the malabsorption, fractures because of calcium or vitamin D deficiencies, abnormal liver tests. You can also have skin manifestations as well. We diagnose it by blood tests. These are very accurate blood tests, about 95% sensitive with picking up disease, but they are not sufficient for diagnosis. In order to diagnose celiac, you must confirm it by taking biopsies, which are just little samples of tissue of the small intestine. You're trying to see that pattern of inflammation of the villi, the blunting of those villi in particular. That's done with an upper endoscopy or a scope. And we treat it by avoiding all foods and beverages that contain gluten. So this is the only autoimmune disease that we know of presently that can be treated completely by dietary restrictions. So once the gluten is removed from the diet, your intestine, your small bowel is completely healed. Okay. The dietary change can be very daunting, and usually you require a dietitian to help you sort of manage that. Just briefly, and I don't think inflammatory bowel disease or short bowel are topics that we can really cover in any respectable manner here, but they are also causes of chronic diarrhea. And so worth mentioning, Crohn's disease and ulcerative colitis are both inflammatory processes. They can occur in your intestines. They are associated with these red flag symptoms for the most part. So watching again for red flag symptoms, those are the things that you point out and say, hey, something's abnormal here. We need to check further or check deeper. And short gut syndrome can be congenital, it can be acquired or surgically created. So kids can be born with disease or parts of their bowel missing or poorly formed. They can have defects in the abdominal wall that cause the intestines to get trapped and have to be removed. And so we can surgically make someone short gut out of necessity. So those individuals are very medically complex. These patients have trouble with absorption of nutrition, of nutrients. They will have chronic diarrhea that's also called dumping, and it's generally associated with what they're consuming. Most all of them require TPN, which is total parenteral nutrition or IV nutrition, in order to maintain their life and their appropriate nutrition and growth. So those patients will always be managed by a team of physicians, not just one. And so definitely can cause chronic diarrhea, but not something that you would need to manage on your own at all. So in summary, we have chronic constipation and chronic diarrhea are very common in pediatrics. The potential etiologies are vast, extensive, and numerous. But most importantly, we really want to hone in on those red flag symptoms. If we're noticing these red flag symptoms, then we definitely want to dig deeper and figure out what else may be going on with the patient. Otherwise, these are, parents can breathe a sigh of relief somewhat in understanding and knowing that they're not alone and that this is very common in pediatrics. So that's all I have for you today. Are there any questions that have come up in your mind? I hope that I did not move.
Thank you, Jessica, for this very informative and wonderful session. I'm pretty sure everyone has learned something insightful today. We'll be taking questions now. If you have any questions, please indicate by raising your hand, or just drop in your questions in the chat box and we'll read them out. Anybody with questions? Okay, while you're still thinking about the questions you want to ask, let me quickly tell you about DiagnoStar. I know Jose already, talked about DiagnoStar in the beginning, but just as he said, we are an integrated health platform, mostly a tech platform that connects patients with doctors, doctors in Nigeria, doctors in Ghana, doctors in the UK, doctors in the US. So you're not restricted to, your location. You just sign up on our platform, and then you get to pick a provider you want to chat with, and then ask your questions, get second opinions about your test results, your prescriptions, whatever it is you need. Basically, you need mental health, health specialist to talk to. You can find them on DiagnoStar. If you want to talk to a pediatrician, you want to talk to a gynecologist, we have a global network of professionals, and we're at your beck and call. You can talk to any of our doctors via chat, via video call, via voice call as well, if you'd like. So we're actually available 24/7 every day. Just sign up on our platform, diagnostar.com. Okay, Mrs. Nduka Ijema says she has a question. Would you like to type that, or would you just want to unmute your mic and go ahead? Hello, Mrs. Nduka, can hear you. Okay. Ikenna Ajana is asking, can celiac disease cause lactose intolerance? Dr. Jessica, over to you.
Yes. So in patients who have celiac disease, because there is damage to those villi, you have a decrease in all of your digestive enzymes. So a lot of patients at diagnosis will be found to have a enzyme deficiency or disaccharidase deficiency. Those generally resolve. I will say it like that. They generally resolve once the celiac disease is being treated effectively and those villi come back to normal. And there's not, blunting of the villi and inflammatory cells sort of mining those cells, the villi themselves. Then you typically will have resolution of those enzyme deficiencies. Now, I do have several patients, I will say that as one caveat, who continue to be unable to tolerate lactose. So I hope that answers your question.
Okay, we have another question from Stephanie Taylor, and she's asking, what do you recommend to remedy constipation for immediate relief? And a follow-up question says, is it acceptable to use a finger to dislodge the constipation?
So for immediate relief, then using a suppository or an enema is acceptable. However, I don't generally, it depends on the child. I don't generally recommend it for kids just because it can be excessively traumatizing. I typically try to instead do, medication from oral medication. So I will give liquid Miralax, so several doses of Miralax, depending on the age and the weight of the child. I will use Senna or Dulcolax as stimulant laxatives to sort of force a contraction of the colon and cause them to poop, depending on the age of the child. So it really just depends on, what age am I dealing with. I don't typically recommend parents to disimpact their child, just because, again, traumatizing, and two, just because we can cause some superficial irritation or bleeding or things like that with removal of the stool.
Okay, thank you, Dr. Jessica. John is asking, he says, thank you for the presentation. Can liquid paraffin be used to treat constipation in children?
So usually, what I would recommend in kids, if lactulose is not available or Miralax is not available, then I would say using like mineral oil only if the child is over a year of age is acceptable. The reason that I stick with Miralax, I'll tell you, is not because they pay me, because they certainly do not. The reason that I stick with it is because it is the most tolerable of all of the options. And I can get kids to actually take it. So you can put it in whatever beverage they want, or you can sneak it into whatever beverage and get them to consume it, and then we can get relief. But trying to take medicine like on a spoon or trying to force that down, again, traumatizing, not going to do it without a fight. So I have not used the liquid paraffin or anything, but so I don't really have a response for that one.
Okay. Brian says, thanks, Doc, for the information. How can we access the materials for this lecture? Brian, after this webinar, you'll get an email, that contains the materials for this lecture. You will have full access to that. Nnamdi Nwankwo, is asking, which specific antibiotics can be used?
For what? Antibiotics for which one?
Okay, that would actually be, Nnamdi, you need to be more specific with your question. In the meantime, Mrs. Ndika, if you're ready with your question, I'd advise you unmute yourself and ask. But if not, okay. Ms. Stanley is asking, is it advisable to administer Miralax to a child in order to prevent constipation?
So if the child has had a history of constipation and you're seeking to prevent another bout of constipation, then absolutely. I use it as the clean out to initially remove the mass of stool or the impaction, and then use it on a daily basis consistently as a maintenance medication. And to keep their poop soft, I sort of make a pact with the child and say, hey, if I keep your poop soft, will you agree to go and try to push out that poop every single day? Because that's the only thing that's actually going to make it better. And so your duty is to keep that stool soft. Remember the post-traumatic pooping disorder, right? So if they have a hard poop again, they're going to remember and react by holding the stool again, and we're back in this vicious cycle. So if you keep their stool soft, they will continually go. If your child has never experienced constipation, then I would not recommend just giving Miralax as a preventative measure in that way. You can wait and watch and monitor, and if they're having issues with stooling or you hear them like straining excessively, then using a dose here or there may be useful or helpful. You also may be able to alter their diet in some fashion to promote softer stools as well.
Okay, thank you, Dr. Jessica. We have a few more questions, I think just two. So is there a nutrition supplement one can use to stop diarrhea in children? This is coming from Caroline.
So that's a very difficult question. And the reason I say that is I typically don't try to stop diarrhea in children unless, so I need to know exactly what the constipation is coming from. I mean, the diarrhea is coming from. So if the diarrhea is something acute from an infectious cause, it will resolve itself. And there's nothing that I need to do to stop it, primarily because I don't want the toxin or whatever may be infecting them to stick around in their gut longer, causing damage or causing more inflammation, which will worsen their symptoms and overall outcomes. So I never really want to stop that diarrhea. We are always taught as pediatricians to feed through diarrhea. You don't hold food, you don't do anything like that. You keep feeding that baby or child through that diarrhea, keep going. Now, if their diarrhea is caused by malabsorption of some sort, then there's not really a nutritional supplement. Really we need to figure out what the child is actually malabsorbing, and we need to replace that or, figure that one out. I don't typically use medicines like Imodium or anything like that in patients without a sincere workup to make sure that there's not one of these other disease processes happening to cause the diarrhea. I hope that makes sense.
All right, thank you. I'm going to take one more question and then we'll wrap up. And this is from Namdi Nwankwo again. He says, with respect to constipation, with respect to constipation, difficult constipation, I guess, involvement in diarrhea, which specific antibiotics can be used? Will it be advisable to use antibiotics and probiotics concomitantly?
So in C. diff infection, you can use either metronidazole, which is Flagyl, or vancomycin, oral vancomycin, which doesn't get absorbed and sort of stays in the gut and can treat directly that way. We use those drugs in the severe infections. In a mild case where we're not seeing elevated white blood cell count, you're not seeing low protein, you're not having a patient who is significantly sort of high risk, then you can choose to wait and watch and monitor and keep them hydrated and all of those things until the infection clears itself. But if you are going to treat, then Flagyl or vancomycin would be your choices, both oral.
Okay, thank you.
And then
all right, I know I said the last one.
Yeah, infant dysphagia is not a pain response, and I do not give any medicine for it. In fact, and I know parents desire you to do something, and I love to get away from that culture. In fact, I will tell them exactly how I'm telling you, that my desire is not just to throw medicine at you. I want you to understand what's going on, because I believe truly in my whole heart that information and education are the most important things, are better than medicine. So if we can understand what's happening, then I can keep you from over treating and possibly harming your child. This is a natural process, just like reflux in babies, that doesn't all require medication. And some of this just requires us to wait through this. It's annoying, it all stinks, and we don't love it. But we're not going to give you medication without a cause.
All right. Thank you so much, Dr. Jessica. That's all the questions we have. Is there anything you'd like to say to, wrap up this session?
Nope, I think that's pretty much it. I appreciate the opportunity. Thank you all for the great questions.
All right. Thank you so much for having us. Thank you everyone for being here today. We have, more webinars lined up for you, basically for your health. We're interested in ensuring that you get premium health care. And that is our main objective. And that's why we're always rolling out free webinars for you to learn. And we also want you to access quality healthcare. That's why we're also giving you access to doctors that are not just in Nigeria, but in the UK, the US, and Ghana as well. And you can access this premium service for as low as 1,000 Naira. You get to chat with and consult with a doctor from any part of the countries I've mentioned. Please do ensure to follow us on our social media handles. We also share very interesting health tips for you that are actionable and very, very important for your health. You can follow us on Facebook. Just search for DiagnoStar Health on Facebook, DiagnoStar Health on LinkedIn, and be sure to follow us. You can also find us on Instagram as DiagnoStar Healthcare. We'll be looking forward to, seeing you on our page, liking and commenting and engaging with our content. Our next webinar will be on dermatology, which is skincare, and we'll be sharing all of that with you very shortly. Thank you so much, everyone, for being with us. Have a lovely, lovely evening.
Thank you.